They are basically null cells, and they have null cells. Null cells means they are the neutral cells. They have the potential to differentiate into different types of hematopoietic precursor cells, which gives rise to hematopoietic mature cells. So the characteristics which are required in a stem cell to have a successful transplant are these. One is the self-renewal, another is the potential of engraftment, still another is the proliferation, which is the multiplication, still another is the differentiation. We don't talk of plasticity. So self-renewal means that the stem cell has the potential to give rise to more cells, and at the same time they renew their potential also. So they remain as stem cell also, and they give rise to more different hematopoietic cells. Engraftment is the quality of the stem cell by which, when stem cells collected from one person are transfused into another person, the stem cells have the potential to go into the bone marrow, sit there and proliferate and differentiate. Proliferation means multiplication. Differentiation means that the stem cell differentiate into myeloid and lymphoid cells, and these cells give rise to more mature cells, and those more mature cells finally give rise to the peripheral blood cells like B and T lymphocytes, NK cells, the red cells, the platelets, and the granulocytic cells. So this is a very harmonized process, well controlled, had a genetic control, had a control by the nutrients, had a control by the growth factor, and then gene control also. So the potential of the stem cells to have self-renewal, engraftment, proliferation, and differentiation. These four characteristics are the basis of a successful hematopoietic transplant. This is the diagrammatic representation of what I said. Now you can see here, this is the bone marrow, and here are the hematopoietic stem cells. Stem cells, as I said, they are generally null cells, but they have the potential under appropriate environment, under appropriate growth factors, under appropriate genetic control, under appropriate nutritional supplements to give rise to various kinds of cells. So this stem cell gives rise to a multipotent stem cell which is little more mature but has almost all the qualities of a precursor hematopoietic stem cell. This cell then gives rise to myeloid progenitor cell and lymphoid progenitor cell. These cells under different conditions can give rise to erythrocytes, eosinophils, basophils, platelets. This is the myeloid progenitor cell. The lymphoid progenitor cell gives rise to T lymphocytes, NK cells, B lymphocytes, and dendritic cells, which are involved in immune system and the presentation HLA transplant में antigen presentation is required in that process. So the hematopoietic cell ultimately over a period of days they give rise to all these peripheral cells which are required by the body for survival. Now, what are the types of stem cell transplant? Now, transplant can be allogenic or autologous. Allo means that the donor is different and patient is different. And auto means the donor and patient is same. That is same patient, same donor. Which donor of the stem cell? Yani in auto, the donor is same and patient is same. Somehow we prime the patient in such a way that disease is eradicated, stem cells are preserved, and those stem cells are then transfused to the patient subsequently. That transplant is called auto transplant. Allo transplant, patient is different and donor is different. So that is called allogenic transplant. Allogenic transplant can be of 3-4 types, depending on the source of stem cell, depending on the conditioning. We will see what is conditioning, depending on the type of donor. If the source of the stem cells is bone marrow, you call it bone marrow transplant. If the source of the stem cell is the peripheral blood, you can harvest the stem cell from the blood. You call it as peripheral blood stem cell. And if you use cord blood or the placental blood as a source of stem cell, you call it as cord blood. So based on the source of stem cell, allotransplant can be bone marrow, peripheral blood, or cord. This is one type of classification. Another type is based on the conditioning. Conditioning is the process by which you prepare the patient for transplant. You will see in the subsequent slide. So if it is intense conditioning, you call it as myeloablative conditioning, and the transplant is the myeloablative transplant. This is the routine or standard approach. Another approach which is utilized in elderly patients who are 60 or 70 or 80, where the conditioning, the process of preparing the patient is less intense. It is called mini conditioning or reduced intensity conditioning. It is also called reduced intensity transplant or mini. This is typically utilized in elderly population. Still another can be HLA matched or HLA mismatched. If it is HLA matched, it has a better result. And if the patient and donor do not have HLA matching and have partial matching, you call it as mismatched transplant. The results, overall results and complications of HLA matched sibling transplant are probably best compared to non-sibling or mismatched. So there are conditions in which you prefer allotransplant, there are conditions where you prefer autotransplant. Depending on these types, the best results are seen with the peripheral blood as far as source of stem cells is concerned. And best results are seen with myeloablation because the cure rate of myeloablative transplants are better than reduced intensity transplant, but myeloablation transplant cannot be offered in elderly population. So this is the alternative. Overall, HLA match sibling भाई या बहन से अगर ट्रांसप्लांट किया जाए, भाई या बहन से अगर स्टेम सेल लिए जाए, तो उसका results are superior compared to other family members or non-family or mismatched. So this is the process of harvesting or extracting stem cells from the marrow. This is the patient is lying here, patient is under GA, and patient is in the prone position, उल्टा patient लेटता है, और ये उसका posterior superior iliac crest is the area where you put the bone marrow needle and harvest the bone marrow stem cells. You can harvest from one side, you can harvest from the other side. This is a cumbersome procedure, and the donor has to be admitted in the hospital and is likely to remain in the hospital for 1 to 2. This is the harvesting of stem cell from the blood. This is the donor, and this is the stem cell pheresis machine. It is just like dialysis machine. The blood is here into the machine. The stem cells are extracted, and the rest of the blood returned to the donor. It is an OPD procedure. No GA is required. No admission is required, and stem cells, equally good stem cells like bone marrow, or in many conditions, it's a better source, more stem cells, better quality stem cells collected from the blood, and the rest of the blood is returned to the donor. So this is peripheral blood stem cells collection. Third is the cord blood. Cord blood is routinely it is discarded, but in the Western world, they have the technology, they have got the systems, they have got the team to collect the cord blood and store it, freeze it and store it. Cord blood is about 70, 80, 90 cc, and it is transfused as a whole. It is a rich source of stem cell hematopoietic. Now, what are the indications of allo or auto transplant? Allo transplant, the main indications are thalassemia, aplastic anemia. Just remember this, thalassemia, aplastic anemia. Malignant disorders main indications are acute leukemia and MDS. MDS is myelodysplasia. So thalassemia, aplastic anemia, acute leukemia, AML, ALL, and myelodysplastic syndrome. They are the main indication of the malignant condition. What about auto? Auto is mainly indicated in lymphomas and multiple myeloma. Auto transplant. Now, decision to transplant is not an easy decision. You need a whole setup, a whole team, nursing staff, your resident team, consultant team, etc. Patient issues, you need to decide based on standard criteria whether this patient needs transplant or he can be cured by alternate treatment approaches. If you decide patient needs transplant, when he can be transplanted, that is another question. Cost has to be justified, family support is required, hospital setup, etc., etc. Once you decide this patient is a candidate for transplant, allo or auto, if it is allo, you need to talk about the donor issue, you need to identify the donor. As I said, sibling donor is the best. भाई या बहन को देखना होता है कि whether they are fit for transplant or not, उसका पूरा workup होता है. Transplant center and experience is important. In Pakistan, there are 3 centers, one in Pindi and 2 in Karachi, who are offering transplant. Cost is about 4 to 5 million. 40 से 50 लाख रुपए कॉस्ट है. फैमिली को आपको जज करना होता है कि फैमिली की अंडरस्टैंडिंग क्या है, देयर सपोर्ट, कंटिन्यूड सपोर्ट बिफोर ट्रांसप्लांट एंड आफ्टर ट्रांसप्लांट. Financial issues, I have already told you, there is a lot of hidden cost also. 40 to 50 is the straight transplant cost. Before transplant, after transplant, लाखों रुपए उसके लिए भी चाहिए. Post-transplant care, frequent visits, blood bank support, rehabilitation, psychosocial support. There are a lot of issues which you have to address before you take a step for transplant. It is simply not this कि transplant कर दो बाकी आंखें बंद. This will not be justified. Steps in organ transplantation. Number one is identification कि yes, इस patient का transplant करना है. ये leukemia का patient था, इसकी disease कीमो से खत्म हो गई है. अब इसको transplant करें ताकि ये permanent cure इसका हो. So this is a long game. Admission is first step in transplantation. Conditioning is the process of giving treatment, chemotherapies plus minus radiotherapy, so that the disease is completely eradicated and patient is fully ready to accept these outside stems. This process, जिसमें mainly chemotherapies or similar therapies are involved in higher doses, and the objective is to finish the disease and empty the bone marrow to accept donor stem cell. So donor stem cell harvest होंगे या अगर auto transplant है तो patient and donor same उसी से harvest होंगे. Infusion is the day 0 is the day when you infuse the collected stem cells, hematopoietic stem cell, whether it is bone marrow or it is fetal blood or it is cord blood. Day 0 is the 0 where you infuse the stem cell. और उसके बाद के जो days हैं, they are called day 1, day 2, plus 2, plus 3, plus 4, and so on. Day plus 365. They are important. 1 year is important. Once you do the conditioning and you infuse the cell, obviously by doing conditioning, आपने patient के hemopoietic and hematolymphoid system को तकरीबन eradicate कर दिया. Eradicate कर दिया तो patient is in severe neutropenia and thrombocytopenia and anemia. So, your stem cells which you have harvested and infused on day 0, they will take time to proliferate. Usually it is 2 weeks for peripheral blood. So you have to manage neutropenia, thrombocytopenia and anemia for initial 2 weeks. This is the time when patient is maximally immunocompromised, neutropenic, thrombocytopenia. Anemia का इतना issue नहीं होता है because you give access to it. And from day 0 you also start immunosuppressive therapy so that जो stem cells आपने लगाए हैं, they are maximally retained and accepted by the patient marrow. Typically methotrexate दी जाती है once a week or so, cyclosporin दी जाती है every day, so that the patient का immune system है, which has been eradicated by conditioning, does not get activated. Why this is important, we'll see in the subsequent. So once patient has been infused with the stem cells and you have started the post-transplant immunosuppressive therapy, IST is the immunosuppressive therapy. Methotrexate and cyclosporin are the standard drug for immunosuppression. So you start assessing the engraftment. Every day CBC is done, every day, to see engraftment is going on. Engraftment is assessed by increasing number of neutrophils and platelets. If they reach at a certain level for consecutive 2 days, neutrophils and platelets, then you can say that our transplant is successful. Patient has been engrafted successfully. So for engraftment assessment, you do CBC every day. Usually engraftment is seen on day 12, 13, 14, 15, 16. By 3 to 4 weeks, patient is quite stable. You then plan discharge by the end of 4 weeks. For follow-up, 30 days, first 30 days, first 100 days, first 365 days are very, very important. This slide, इसकी डिटेल में ना जाएं, just focus here. Day 0, this is the day 0. Here is the day 0. This is the day 0. This is the day where marrow is infused. This is the bone marrow transplant. Day 0 is the day where you infuse the marrow. So this red line shows the hemoglobin. So you transfuse the bone marrow here, and this is the time when patient is maximally neutropenic and thrombocytopenic. Just see the black line and the blue line. This is the blue line, which is for neutrophils, and black line is for platelets. And this red is hemoglobin. This is day 0. So to assess the success of an graft, you need to monitor CBC every day. So this is day 0, and this is here the platelet count is 10,000. Because of conditioning, marrow is almost burned. Myeloablative conditioning होती है, very heavy doses of chemotherapeutic drugs are given to eradicate the disease and to make space in the marrow for the stem cells to be transfused. This is blue line. This is almost 0.2. Neutrophils are 0.2. This is extremely low. This is week 1, then plus 7 days, plus 14 days, plus 21 days, plus 28. So every day you do the CBC and you monitor the success of the transplant by increasing number of platelets and increasing number of platelets. So you see platelet of 20,000. 20,000 is here, week 3. So week 3, this is the week 3, day 21. This is the time when the platelet count has gone to around 20,000. Initially it was 10,000 here, it was 10,000 here, and now it is 21,000. So this is अगर consecutive 2 दिन platelet 20 or above रहे, or neutrophil count 500. This is 500. You can see here 0.5. So if the neutrophil count at week 3 is 500 and is going up, and platelet count at week 3 is 20,000 and is going up, that means your transplant is successful. If it does not go up, it means there is transplant failure. Failure की वजूहात बहुत सारी हो सकती हैं. Now, coming to the acute complications of transplant, I will not go in detail. Infection, obviously, because of severe neutropenia and immunosuppression, infections is a major threat. Acute graft versus host disease. Graft versus host disease, हम देखते हैं आगे क्या है. Graft failure or rejection, they both are opposite. In one of the diseases, the donor immune cells present in the stem cell bag, they are dominant, and at another, the patient immune cells, they dominate. So there is a fight between the immune system of the patient and the donor. If the patient wins, it is successful in rejecting the graft, we call it as graft rejection. If the patient's immune system is strong and they reject this patient, then it is called GVHD. Normally, we have to keep a balance so that there is no enhanced GVHD, no enhanced rejection, so that transplant is optimized and is successful. Otherwise, these two complications, if they are advanced, they are nasty. They compromise the quality of life and the outcome. VOD is veno-occlusive disease of the liver. It primarily involves the liver. It is a bad complication. These are other complications: bleeding, pneumonitis, hemorrhagic cystitis, cardiac failure, etc. They are all acute complications. So Initially patient is immunocompromised and neutropenic for about 3 weeks. 3 weeks are very crucial. This is day 0, day 50, day 100. So initially the major threat is viral infection and gram negativity, followed by fungal infection. These are the major problems during the period of neutropenia. Uh, Patient remains little more immunosuppressed for about 100 days. इस दौरान में कोई भी इन्फेक्शन होने का चांस ज़्यादा है और उस लिहाज से पेशेंट को एडवाइस करनी होती है और इसकी रिहेबिलिटेशन. Now coming to the immune complications, there are two major immune mediated complications. One is graft versus host disease and another is rejection. तो ग्रैफ्ट वर्सेस होस्ट डिजीज इज ए नास्टी कॉम्प्लिकेशन. ये होनी तो सब में होती तो सब में, लेकिन मेजॉरिटी में इट इज माइल्ड मैनेजेबल एंड दे आर आउट ऑफ इट एंड दे डू वेल फॉर लॉन्ग. लेकिन जिसमें ग्रेड 4 हो जाए या ग्रेड 3 हो जाए अनकंट्रोलेबल, उसमें कंप्रोमाइज द क्वालिटी हो. So this is the nasty complication. Why it happens? It happens because donor immune cells, which means lymphocytes, in the graft reject the recipient tissue. जो स्टेम सेल का बैग आप लगा रहे हैं उसमें आपने बोन मैरो से स्टेम सेल निकाले, दे आर नॉट प्योर. उसमें लिम्फोसाइट्स भी हैं, डेंड्रिटिक सेल्स भी हैं, मैक्रोफेजेस भी हैं, ब्लड के सेल्स भी हैं, फैट सेल्स भी हैं, रेटिकुलम सेल्स भी हैं, हर किस्म के सेल. तो lymphocyte जो है, if these lymphocytes identify the patient as foreign and they react vigorously, that leads to acute graft versus host disease, which is typically seen in first 100 days. After almost every transplant, there is some degree in most of the patients, some degree of acute GvHD. In majority, it is grade 1. In some, it is grade 2. This is easily manageable. Grade 3 and 4 takes time, and if they become, more complicated, then it compromises the quality of transplant. So it is the dominance of the donor lymphocytes who reject the patient tissue. Which tissues are affected primarily? Skin, liver, gut, and hematopoietic system. High mortality if grade 3 or 4. This detail is not required for you. And this is acute. Chronic GvHD, same cause, same philosophy, same reason. But if it occurs, GvHD occurs beyond 100 days, you call it as chronic GvHD. Chronic GvHD is less life-threatening, but it compromises the quality of life. ये acute pattern है GvHD का, acute GvHD का, skin, liver, gut. ये आप याद रखें, बस इतना सा, इससे ज़्यादा डेट की आप. Now we talked about graft versus host. Another complication, immune complication, is graft rejection occurs here. Rejection is part of the graft failure. There are many causes of graft failure. अगर आपने stem cell लगाए हैं और stem cell viable ही नहीं है, dead हो गए for your poor technique, तो graft engraftment नहीं होगी और patient को पे जो आप न्यूट्रोफिल काउंट और प्लेटलेट काउंट मॉनिटर करेंगे उसमें इंक्रीज नहीं होगी. या अगर स्टेम सेल वायबल है लेकिन उनकी क्वांटिटी बहुत कम है तो भी एनग्राफ्टमेंट नहीं होगी. सो दीज आर causes of graft failure. Low CD34 dose. CD34 is a marker of stem cell. अगर बोन मैरो में फाइब्रोसिस है या ऑलरेडी डैमेज है बोन मैरो तो भी एनग्राफ्टमेंट कामयाब नहीं हो. अगर HLA डिस्पैरिटी बहुत है या पेशेंट को इन्फेक्शन है ड्यूरिंग बिफोर द ट्रांसप्लांट तो भी ग्राफ्ट फेलियर का चांस. The important cause of graft failure is immune mediated, and it is called rejection. It is just opposite of GVHD. Rejection में it is the lymphocytes of the patient who reject the graft. जैसे आपने किडनी किसी को ट्रांसप्लांट किया, मुझे किसी ने किडनी दिया, मैंने किडनी लगवा ली, बट डॉक्टर ने कहा आपका किडनी रिजेक्ट हो गया, which means my body has rejected the donor tissue. Similarly, the patient lymphocytes reject the graft, reject the hematopoietic cells जो उनको transfuse किए, and that leads to graft failure, and that is called rejection. So GVHD and rejection are opposite to each other. Both are mediated by lymphoid cells and other immune cells. In GVHD, it is the donor lymphoid cell which dominate and win the war. In rejection, it is the patient lymphoid cell which dominate and win the war. Though both are nasty complications. This is the late complications of stem cell transplant. We talked of acute early complications, infections, bacterial, protozoal, fungal, and viral. We talked of GVHD, we talked of VOD, hemorrhagic cystitis, myocarditis, etc., etc., VOD. These are late complications. Late complications means beyond 100 days. Again, infection, bacterial and varicella, particularly viral infections, are common. Chronic GVHD is one, I already told you. Chronic pulmonary fibrosis. Autoimmune disorders are very common as chronic complication. Infertility, late secondary malignancies after about 5 to 10 years of transplant. Infertility issues. So they are the general problems which a significant number of patients face. इसीलिए कहते हैं कि transplant is not a static process. It is not a 1 day or 1 month's game. It is a lifelong game. Now, what factors determine the BMT success? That is important. इसकी डिटेल में हम नहीं जाएंगे, आपके कोर्स में नहीं है. Age, early age, बच्चों में transplant success overall is much better than middle age than late. Disease and stage. Early disease and early stage of disease like thalassemia अगर newly diagnosed है, 1 साल उम्र है, या कोई AML newly diagnosed है, younger age है, उसमें results are. I told you HLA match, sibling transplant, HLA matching is mandatory. Now mismatched transplants are also done. लेकिन अगर HLA matching है और अगर भाई बहन से है, तो उसके results are superior compared to non-HLA match or non-sibling. ABO group is important, but it is not a major barrier. अगर ABO group match है, तो results are likely to be better. अगर mismatch है, तो भी transplant हो. Stem cell source, I told you, probably peripheral blood is the best source compared to bone marrow, compared to bone. Type of conditioning, again, type of conditioning can be myeloablative or non-myeloablative. Non-myeloablative में जितनी complications बताई हैं उनके होने का चांस कम है, लेकिन non-myeloablative चूँकि कंडीशनिंग इसमें ज़्यादा सख्त नहीं होती है, इसमें डिजीज रिलैप्स का चांस ज़्यादा. माइलोअब्लेटिव में कंडीशनिंग क्योंकि स्ट्रॉन्ग होती है, एब्लेशन मीन्स जला देना, माइलॉइड सिस्टम को जला देना, तो उसमें कॉम्प्लिकेशन और ट्रीटमेंट रिलेटेड मॉर्टेलिटी ज़्यादा. डोज ऑफ स्टेम सेल इज इम्पॉर्टेंट, इसकी डिटेल में हम नहीं जाते, बट देयर हैज टू बी एडिक्वेट डोज फॉर द पेशेंट. इम्यूनोसप्रेसिव थेरेपी जो हम ट्रांसप्लांट के बाद देते हैं एज ए पार्ट ऑफ GVHD prophylaxis, that is also important. Experience and interest of the doctors and hospital and support service is also very, very important. Now, maybe this is the last slide, and this is I'm going to talk about the outcome. Pakistan में thalassemia is the major disease which is offered transplant. हमारे यहाँ thalassemia बहुत ज़्यादा है. Western world में thalassemia नहीं है. Western world में malignancy is the major disease which is transplanted. हमारे यहाँ it is thalassemia and aplastic. Both are much more common in developing countries like Pakistan than the malignancy. Thalassemia, again, depending on the factor, success rate is 60 to 90. Acquired aplastic anemia, about 70 to 85. Acute myeloid leukemia, acute lymphoid leukemia, less than 50%. Myelodysplasia, less than 50%. Autotransplant, I told you, autotransplant is typically done in lymphoma and myeloma. Auto means कि पेशेंट अगर किसी पेशेंट को लिम्फोमा है, आप उसको कीमो दे के उसका लिम्फोमा ख़त्म करते हैं, उसका सीबीसी नॉर्मलाइज हो जाता है, इम्यूनो सप्रेशन ख़त्म हो जाता है, फिर आप उसके स्टेम सेल इकट्ठे करते हैं, बोन मैरो से करें या ब्लड से करें या तो पेशेंट एंड डोनर इससे स्टेम सेल लेके आप उनको फ्रीज करके आप इनकी कंडीशनिंग करते हैं, इनको हाई डोज कीमो देते हैं ताकि इनके जो अगर कोई डिजीज़ है कहीं रह गई है तो वो ख़त्म हो जाए और मैरो में जगह हो जाए. फिर वो जो फ्रीज सेल हैं उनको आप रूम टेम्परेचर पे लाते हैं और फिर इनको इन्फ्यूज़ करते हैं. तो इन ऑटो which is done in lymphoma and myeloma, the patient and donor remain safe. Lymphoma में success rate is around 40-50%. Myeloma is not cured, but survival is improved for 3 to 5 years. अब बहुत सारी दवाइयाँ भी आ गई हैं जो माइलोमा में सर्वाइवल 4-5 साल तक बढ़ा देती हैं. So maybe आने वाले टाइम में transplant in myeloma. With this, I close my talk and thank you very much for your patience. Unfortunately, online is a one-way traffic. You can listen to me, you cannot talk to me. There is no interaction, but what to do?